Hi, I'm Dr. Carlos Brun. Welcome to this video on the lung exam. Why do we use ultrasound to assess a hypoxemic or hemodynamically unstable patient? Well, the ultrasound can be used to rapidly assess for pneumothorax, both clinically significant or non. You can also see if there is a normal lung. And in future video, we would like to show you even more subtle aspects of the lung exam. But for now, we're going to focus on pneumothorax versus normal lung. How are you going to do this? Well, let's get to practicing. We're ready to discuss lung ultrasound with a different probe this time. Notice I have the vascular access probe with a maximal depth of 6 centimeters. We've also marked this probe with an orange tape to indicate where the indicator notch is. Now, the reason we're doing this is because when you're doing vascular access, for example, using ultrasound for an internal jugular access, you already have this probe, and so you may wish to rapidly assess the lung ultrasound prior to doing an invasive procedure, and therefore you can do it immediately after the procedure to look for possible complication. So, same principles as before. You will hold this in a pencil grip. You will search the midclavicular line, and in the supine patient, the most superficial portions would be the 3rd to the 5th intercostal space, and gas rises. So that's where we're going to look for pneumothorax first. Sterile gel doesn't have to be sterile. It's what we happen to have. So you can always put more gel on the patient than you can on the probe. Take our image, and we want to be perpendicular to the pleura. Now we look to the ultrasound screen, and we see that we're kind of in between where we wish to be. What we want to do is identify a rib, which we suspect is here in the middle of our screen right now, because there is no ultrasound beams passing below what we suspect to be this portion of the rib, because bone would not allow beams to pass. You would move either towards the patient's feet or towards the head, depending upon where you wanted to image, and you'll identify another rib with shadowing. So in between those ribs should be a pleural line, which is going to be located at the base of the rib shadows, and it should be a thin pleural line, and it's a hyperechoic line. So what we see is at the top of the screen is superficial skin, subcutaneous tissue, pec major, minor, and intercostal musculature, and then we have this bright white line, hyperechoic, and it actually seems to be scintillating or moving. Now, this is what's known as lung sliding, and it is indicative of a normal lung. If my patient takes a deep breath in and out, perfect. You'll see that that white line appears to move. And that's what we want to see. This implies the visceral and parietal pleura are actually moving along, and that's what you're seeing. Now, if he could take small breaths, sometimes you can see it, but it can be more difficult. So you can breathe normally now. Thank you. So things to think about would be, if right now we're on the right-hand side of the chest, you could have a right mainstem intubation, and that can cause normal lung sliding on the right and abnormal on the left, because this is a bilateral exam. You could have issues with inflammation not allowing you to see the lung moving. This can be indicative possibly of consolidation or inflammation. And so that may be a tethered lung to the pleural surface, and you may not have moving. Another potential pitfall could be that you have a bleb. And then, of course, what we're looking for would be pneumothorax. So you may not see it clearly moving line with pneumothorax. Now, this is the one time where we might want to use the M mode or motion mode. And what you do is you touch the button once, and you get a line guide, and you hit it again. And what this does, it's kind of an ice pick view through that one indicator line. And it's going to give you time in the x-axis and movement on the y. And so it'll give you kind of time resolution, so very fine detail of moving structures over time. And what you can see here is a very specific sign, the seashore sign. You see the non-moving tissue above the pleural line, and that looks like waves. And below the pleural line, you see the motion of the tissue reflected as what appears to be sand, sandy beach, or the seashore sign, a very calming sign that's indicative of normal lung. Back to 2D. So those are indications of normal lung. This is the maximum depth that we can see. So you may not see some of the other lung signs, such as an A line, because you don't have a total depth. So we'll go over that again in the FATE examination. For a pneumothorax, what you may see may be air underneath the pleural line, and therefore some compressed lung or no movement. And another indicator could be lung sliding, and that would be where you'd see a dark area move in with respiration and expiration in and out of what this window may be, impeding with the lung sliding. Now, this is a complicated description of something that is visually pretty obvious, but essentially it would look like darkness coming in, loss of lung sliding, and then coming back to a complete lung sliding, and that can be indicative of pneumothorax. Remember, this is clinical context, so you need to have a reason for pneumothorax, and you might not want to jump to decompression right away unless your patient is needing mechanical ventilation or is hemodynamically unstable. You need context. Just because you think you see it on ultrasound does not mean you need to put a needle in it. So this is the basics of the pleural ultrasound. One other thing you could potentially do would be to place color on this, but we will discuss that in a future module. Remember that this is a bilateral examination. If we go over to the left side of the chest, we see again a rib, see another rib, and then you can sometimes see motion from the heart if we keep coming down. And do not be confused with that being a pneumothorax, because we're on the left side of the heart. So that's another potential pitfall. So if I move up, you can see this. And even if our patient can hold his breath for a moment, you can see some slight movement, and you can breathe now. Thank you. Those are known as cardiac oscillations, and you have transmission of the cardiac impulse through the lung tissue, causing this kind of artifactual pleural line movement. And that would mean that there is no pneumothorax, because it's, the heart is transmitting its pulsations through the lung tissue, and you can see it at the pleural line. So don't get confused with that either. I think it's time for some practice. Nicely done. Let's summarize what we've just discussed. We have learned how to utilize the ultrasound to assess for pneumothorax versus normal lung. We can use a phase array probe from the cardiac exam or a vascular probe, as you use with IV or central venous access, to assess for normal or pathology. I want you to remember that this requires practice and vigilance. And while you've completed this video, you're going to need to practice with someone who is skilled in this technique. And you'll be able to rapidly use it clinically after that. Other tips for you. Remember how to do this exam. You're going to grip the probe with a pencil grip. You're going to start to place it in the midclavicular line, 3rd to 5th space for the supine patient, because air rises. And you're going to select either a cardiac or a pulmonary exam on the ultrasound. Your depth can be anywhere between 6 to 16 centimeters. The angulation is going to be perpendicular to the chest wall, and there's no need for rotation or tilt for this exam. There are pitfalls to this technique. Please remember that if the patient is apneic, or if you're checking the left side of the chest and you have a right main stem intubation, you may not have lung sliding present. You may not have lung sliding present if you have adhesions or a pneumonia with consolidation that causes inflammation. So those pleural surfaces will not be rubbing together. You may also see this with blebs as well, or severe ARDS causing similar inflammation. So remember these pitfalls. Not everything you think is air needs a needle. That's when you need to have help with assessment and possibly other imaging modalities. So go practice. Well done.